I'm Indy. I'm a midwife and I'm a medical anthropologist. And I have been working in Gurage in Ethiopia for almost a decade now. And I work alongside a team of local midwives, local nurses, and we have a small birth centre and a clinic, a health clinic to serve the population. I first went out there in 2016, the beginning of 2016, to work in one of the rural hospitals. And that was on a short-term 1-year project to help them establish a neonatal unit. Through being there and talking to the midwives, in particular at Atsede, who went on to become a very good friend of mine, we sort of realised that the hospital provides that level of life-saving care that's really important. But for women who don't need to be in that setting, if we could take them away from the hospital and take that strain off the resources that the hospital has, which are very limited, then we could provide an alternative place for birthing that was much more, family-centred, community-centred, driven by sort of one-to-one midwifery care. We're very focused on doing community-based care. So we have a good team of community outreach advisors, and they go into the villages and they ask, the families what would be most helpful. And the feedback quite quickly was for lots of women, getting to health facilities for antenatal care, for postnatal care is very, very difficult. There are lots and lots of barriers, lots of challenges. And so they came back with that, and we came up with the idea of sending midwives to them. So identifying women in the villages who wouldn't be able to access healthcare and making sure that despite that, they would still receive, really good quality, comprehensive antenatal and postnatal care with our midwives. So our midwives go with sort of like a mini lab, and we have an portable ultrasound machine as well. And with both of those, we can send teams of midwives out to see. We see about 250 women as part of this program, and they each have on average 3 or to 4 antenatal appointments in their own homes. Actually, she's a Gurage midwife, a local midwife. She grew up in one of the villages a stone's throw from the hospital, and her father was a cleaner in the hospital, and then a nurse's aide, and then a nurse, and he sort of introduced her to the concept of working for the hospital and giving your life in service to the women. So she followed in his footsteps and became a midwife. And she was actually the first woman in Gurage zone to be trained as a midwife specifically, rather than as a nurse, sort of moonlighting as a midwife. So she was a real trailblazer. And she worked as the labour ward coordinator, and then the manager, and then the overall sort of service director for maternal health in the hospital. So when I turned up 8-9 years after she first started, she was my mentor and my tutor and my friend, and then my colleague and my boss now, well, co-boss, as I like to say. So, and we opened the clinic together, we lived together, we had our children together. She was my midwife, I was her midwife, and even though we spend, pretty much all of our time together, we don't seem to disagree on too many things, which is quite nice. And she's our consultant midwife, so she takes the lead in all the clinical cases. And it was always very important to her, and I completely agreed, that this should be an initiative and a project and a programme driven by Gurages, which is the area we're in, so Gurage women and the Gurage community. So that's why she's very, very much in the lead. And I do what I can to help her in the background and learn everything that I've learned about being a midwife from her as well. The people around us, the families around us, they're living on the poverty line. So nobody has disposable income. It's very much a hand-to-mouth existence, which means any charges in healthcare, especially for girls and women, tends to be low down the list of priorities of what families think they can afford. And then Ethiopia Aid sponsoring the outreach projects was amazing. It was such a weight lifted for everybody, and it meant we knew that we could go and find the women and the populations who were really marginalized in our areas, who couldn't even afford to think about going to a health centre, And it meant we could know that we could access them and continue to access them. And then as the years went by, we were also able to expand that into postnatal care as well as antenatal care. And it meant we could encourage these women to come to the clinic or other health facilities, depending on which is most appropriate for their births. And now we're starting to see, in a really solid way, after 2 years of collecting data, a reduction in maternal morbidity and mortality and neonatal morbidity and mortality. So it was a huge thing to know that we could continue this program. And we're seeing women come back for their second and their third babies, and they've been with us from the beginning. And they've told their sisters, and their sisters have told their friends, and word gets out. So the messages that we give to the women in our programs extend beyond the borders of it. And so we can see the trickle-down effects as well, which is really, really amazing. I think lots of people want to give a little bit of money to a charity, and they often think, oh, I've only got £10, £20, it might not make a difference. But after you've been working, in aid, you realise that, especially in the way that Ethiopia Aid supports charities, they choose local charities on the ground. And we don't have hundreds of thousands of pounds coming in that we spend on overheads and, consultants or anything like that. Every penny and every pound that comes in goes directly into the project and directly into benefiting the women, the families who we look after. So just a huge thank you to everybody, and you never discount that whatever you can and do give, it makes a difference. It has a direct impact on women's lives for us.